Okay. So everybody is ready? So, good morning again.
Good morning.
My name is Ahmad Nosrati. I'm a board-certified dermatologist. I'm from Iran. I've been in this field of dermatology for more than 30 years. And in this long career, I've been working as a faculty member in a teaching hospital, in a private practice. And currently, right now, I am teaching cosmetic procedures to the practitioners and also medical staff. So we are going to talk a little bit about the dermatology. I don't know whether you have any study before in and any knowledge about dermatology. So before that, I want to give you a heads up because dermatology is a little bit different from the rest of the medicine. In most of the disciplines in the medicine, you are dealing with the numeric data. This numeric data is easy to grasp, easy to compare, and easy to build algorithm or any kind of these treatment plans according to that one. For example, you can check the blood pressure, it comes a number, so you can compare this number with the other number. On the contrary, dermatology is highly visual and descriptive. So it will be a little bit confusing at the beginning because we are not talking about the numbers, we are talking about the qualities. So let me give you an example so everybody knows that how is the red color is, right? But you know that the red in the apple is different in the red in orange or in the tomato, right? So these are different reds. So even you don't need to see the whole fruit, you can recognize this going to be red like apple, this going to be like a tomato. So this is the way that things goes in dermatology, so it's very visual. For this reason, you have to train your eyes to recognize these subtle differences in the diagnosis and also recognizing the different conditions. So I just want to take 2 minutes again and tell you why we should study there, right? So dermatology is an orphan specialty because first of all, in the eye of the medical students, you are not going to save lives, right? Everybody wants to save lives and nothing in dermatology to save life. And also most of the time when you remember a dermatologist, you remember a teeny tiny blonde lady. Sorry guys, I am here with you, unfortunately. And then they are just looking at this beauty stuff or pimples or something like that. But in reality, if you go to be a family physician, for example, around 15 to 20% of your client or your patient will come with a dermatology complaint. So it is a very common. I can say that after your graduation, after you go to the practice, the first thing that you are going to buy is a dermatology book because you will see case after case coming and you don't know what they are, what to do with them. If you see in the ER, the horrible thing that somebody comes with a fever and rash, so everybody confused, this is a rash, you don't know what it is, right? Plus, many of the other systemic diseases, they have some skin manifestations. And then because skin is a very accessible, very easy to look and examine, you can find clues under skin if you look, be familiar with the skin diseases, to guide you in your diagnosis and also to make a differential diagnosis and save some time and money to doing maybe more invasive procedures for the diagnosis. And the last but not the least, skin disease has highly impact on social and psychotic well-being of the people. Imagine tomorrow morning, you just lose one of your eyebrows. Your whole life will be stopped. It doesn't look that bad if you see that, okay, people, you have lost a few hair follicle, or you will get the white patches in front of your face, or you get the bald patches on your skull. So these are the things that it doesn't look that serious, but really can ruin the life of the people. So it's very important to take this dermatology disease seriously because really they are important for the people. And you never know until you get one of those, right? Okay. So that's what happened. I talked too much. Okay. So I try to be very quick, very fast for the sake of time. And we are talking about a little bit of this structure and function of the skin. And today we are going to discuss about the basic principle of how to examine the skin, what is the primary lesion, what are the secondary lesion, and a little bit we talk about these different tests that we do, a little bit of the immunology, a little bit of the pathology. So I try to create a small dermatologist in each of you so you can recognize at least the skin diseases, or when you go back to the your lectures or your books, you will understand what they are talking about. So because I don't like to speak alone, I want to invite people to join me and tell me what the function of the skin you think. What are the function of the skin?
A barrier.
Okay.
Protection.
A barrier? Barrier to what?
Protection against infection. Pathogens.
Okay. A barrier to what? More important than the pathogens. Because this is the very fundamental issue that in the whole dermatology we are going to talk about this a lot. How much of your body is made of water? 70%. And you are living in a dry outside of the water. So which organ keeps that water inside the body?
Skin.
The skin. So holding the water is the most important thing the skin does. Plus it keeps the interior environment separate from the outside environment. And then beside that, skin has an immunologic organ. It protects and it works as a sensation. And in temperature regulation, your effector organ is skin, and also in production of the vitamin D and the appearance and the quality of life. So let's dig a little bit on this, some of the most important one. As I told you, the protection against the water is the most important thing is that. And then when this protection or the barrier is gone, you will have some transepidermal water loss, you will end up with some inflammation, with some infections. The skin is a home for so many different kind of the active cells in the immune system, and it's a big immune organ. And this is just to tell you that how much the skin disease affect the quality of life of their sufferer. So it has a big impact on the psychotic health and the well-being of the people. Okay. So what are the structure of the skin? The skin contains of 3 layers. Everybody knows that, right? Epidermis, dermis, and the hypodermis. And then this is the graph of this slide of this cut of the skin. So you see the different thickness of the skin in reality. So you have on the top is the epidermis, and then you have the dermis, that's the connective tissue, and the subcutaneous, that's subcutaneous fat. So I don't want to go through all details, but remember that we have 4 types of the cells in the epidermis. These are the keratinocyte, melanocyte, Langerhans cell, and the Merkel cells. The bulk of the epidermis is made of these keratinocyte that they are in different layers. So from this basal layer all the way to the squamous layer. And then you have the stratum basale that's sitting in one cell, cubical on this top of this basement membrane, and they are dividing so fast and replenishing the cells that come through the epidermis. So then you have, as the cells moves up, they become flatter, and they develop these desmosomes, and they produce keratin. That's the main product of the cell, and also they produce some other material like filaggrin and also these lipids that slowly when they move up, the cells fill with this material, and they lose their nucleus, and they become dead cells and produce the cornocyte. That's like a flat sheet. They attach to each other, and they produce that stratum corneum. So in the stratum corneum, you have these cells that contain this keratin filament, and there is a cement between them that is made of the lipid material. This lipid material is also produced by the keratinocyte. So the major lipids we have in this barrier is called ceramide. So if you have looking, for example, have you go to buy some sort of this moisturizer, you are talking about the ceramide containing moisturizer, because the ceramide is the main lipid that produce that is available in this stratum corneum, and they protect the prevent the water loss. If you look at this distance between the epidermis and the dermis, you will see this is not a straight line, right? So on the top you have the epidermis, and on the middle part, lower part, you have the dermis, that is the connective tissue. So you will see that this is not a straight line. There are some invasion of this epidermis into the dermis that we call these rete regions. And there is a space of this between filled with this some part of the dermis that we call papilla. So these are the rete regions, and they are the papilla. And you know that the epidermis is ectoderm, the dermis is mesoderm, and these two layers are attaching to each other. So this attachment comes as a specific structure called basement membrane zone. This basement membrane zone contains several types of the glycoprotein and proteins that spread from the inside of this basal keratinocyte all the way down to the upper part of the dermis. There are different structures there. The importance of this structure is that they are a good target for immune system that produce blistering disease, and sometimes they have genetic issue in these proteins that create some congenital disorders. But just remember that this basement membrane zone is the layer that attaches these two different tissues together. So keratinization, basically, this is the big story here. As I told you, from the basal layer, cells grow upward continuously, and during this movement upward, they become flatter, and they go through two processes. One process is synthetic process. They synthesize these keratin filaments that give strength to the epidermis, and also synthesize some lipids that come to the outside of the cells and produce that cement between the cells. As the cells go up, then there will be a degradative phase. The cells slowly filled with this material, lose their nucleus, lose their organelles, and they die, and they become completely lose all the cells, organelles, and they become died. So at the surface, then slowly the cells flake off, and then this cycle continues. So basically, this is a renewal cycle that takes 28 days. So from the basal layer to the stratum corneum, it takes around 14 days. And from the stratum corneum, cells stay there for around 14 days until they shed. So this is called a terminal differentiation, because the cells, through this differentiation, the cells are dying and basically creating that stratum corneum, that the final result of this differentiation. So the whole story of this skin, whole story of this structure is to create that dead layer of the cells that works as a barrier. So any problems during this keratinization, during this differentiation, creates so many of these, the origin of so many diseases. In some diseases like psoriasis, for example, these travel times instead of 28 days become 3 days to 5 days, even sometimes a week. So as a result, there will be higher turnover. Or there are some, for example, genetic defect in production of the keratin or these genes that create, for example, effective keratinization or ineffective shedding, basically. So the cells does not separate one by one, because on a regular basis, you won't see the shedding of your skin, right? Any questions so far about the keratinocyte? Is crystal clear? Fabulous, okay. So let's talk about the melanocytes. These are the pigment-producing cells. For example, for each keratinocyte, we have one melanocyte. They are sitting on the basement membrane zone, and the others, the top layer, you will see this special staining, show the distribution of the melanocyte in the natural skin. So inside the melanocyte, we have an organelle called melanosome. That is, melanosome produces the pigment melanin from the tyrosine, and there is an enzyme that Tyrosinase is a rate-limiting enzyme, and we have two kinds of the pigment. One is called eumelanin, that is the black and brown, and you see the other one is pheomelanin, that is red and yellow. And the combination of these two depends the tone of the skin. So for example, you will see very dark people, they produce a lot of eumelanin, and the white people produce a lot of eumelanin. And all these shades in between is related to how much genetically you produce each of these. So we have different tone of the skin from white skin to dark skin. Please remember that the number of the melanocytes are different based on different parts of the body. For example, on the sun-exposed area, the number of the melanocytes are much more than the covered part. But the number of the melanocytes in white skin and dark skin are the same. So the very dark skin and very white skin, they have the same number of the melanocytes. The only difference is their activity. In dark skin people, melanocytes produce bigger melanosomes. They spread widely and then all over, and they remain until the upper part of the epidermis. While in the white skin people, usually they produce smaller melanosomes. They try to pack together, and usually they degrade in the lower part of the epidermis. So the difference in the color tone is just because of different melanization, not the number of the melanocytes. We have Langerhans cells. These are the dendritic cells. These are the bone marrow origin. Again, here you will see the distribution of this Langerhans cell in the lower part of the epidermis. This is special staining because you cannot see in light microscopy. And they are the first line of the defense. When somebody extra material comes into the skin, they pick that one and then transfer to the lymph nodes and present this to the immune system. So they are very critical cells in many diseases. We are going to talk about that in the future. And we have the Merkel cells. These are the Merkel receptors, sits on the basal layer as a single cell. Again, this is a special staining to show one of them. And they work as a sensory organs. What other sensory organs we have in the skin?
Free nerve endings.
Free nerve endings is for the pain, for the touch, for example.
Pineal corpus.
Pacini corpuscle, and then this is Pacini is sitting deep in the dermis. These are for the pressure and vibration, and for the sensation. Push hard. Meissner, right? They are on the papillary dermis. Right? Okay, that's it. Okay, great. So we have the dermis. In the dermis, this is a connective tissue. We have two important fibers, the collagen fiber that constitute about 80-85% of this volume of this dermis. And then we have the elastic fibers that they are around 4 to 5%. And we have a feeling substance, the grand substance, that is made of the glycosaminoglycan. The very famous one of this is hyaluronic acid. So you know that everybody talks about the hyaluronic acid. This is basically the glycosaminoglycan sitting inside between the fiber. And then we have the other structures over here in the dermis. We divide the dermis basically in two parts. The top parts, that is a loose connective tissue, is called papillary dermis, and this is highly vascular, and the lower part is called reticular dermis. Basically, we are talking about the nomenclature. When you go to the disease, you say this is in the reticular dermis or it's in the papillary dermis, you know where they are. The subcutis is made of the fat and a little bit of the connective tissue, and then we have the adnexal structures. These adnexal structures are basically the skin appendages. They are the pilosebaceous units, sweat glands, and hair and nail. That we are going to a little bit talk about the importance of these different organs. First of all, the pilosebaceous unit. The pilosebaceous unit contains the hair follicle and the sebaceous gland and the arrector pili muscle. So we divide usually this pilosebaceous unit in three parts. The top part is infundibulum, is from the surface of the skin to the insertion of the sebaceous duct, and the second one is the isthmus from this sebaceous duct to the insertion of the arrector pili muscle, and the last part is the inferior segment that contains the bulb, that is the matrix, and the papilla. Hair papilla is the It's connective tissue that's sitting inside this and provide the vessel. This separation is very important again because the lower segment is the segment that go through cycle. So during the growth cycle, they grow and they produce the hair, and when it's going to the resting cycle, it shrinks down and go back. So basically, this bulge, little bulge here, is the place that the stem cells of the hair follicle reside there. So the upper two segments is constant, but the cycling one is this lower segment. Again, it has some important implication because if you have any inflammation in the lower segment, most probably you are not ending with the permanent hair loss. You will have temporary hair loss, the hair loss that's going to be treated, recover. But if you have any damage to this bulge area, then there will be a scarring hair loss, the hair loss that will never recover. So that is the most important thing about that. So, you know that hair structure, we have the hair shaft composed of different cell layers, and then we have the inner root sheath and the outer root sheath and the connective tissue around that. These are too much details. But here that you know that the hair doesn't grow continuously, it goes through cycling. So we have an active growth phase, that is the anagen phase, and we have the transition phase, that is the catagen phase. You know that this lower segment shrinks. And then we have the telogen or resting phase, that there is no growth, and then the called exogen or early anagen. There is when the new hair start to grow, and the old hair will come out. So in some animals, all this hair cycle are simultaneously. So you will see the shedding of that. But in human, it is random. So for example, one hair is maybe in the early anagen, the second one is the nearby is in the catagen, the nearby is in the telogen phase. So you don't have sudden shedding like shedding we have in some animals. But you know that these hair are completely cycling. And the length of the hair is dependent on the length of this anagen phase. For example, if you don't cut your hair, you know that the hair will grow, right? But you never cut your eyebrows, right? Why is that? Because over here, the anagen phase is short and the telogen hair is long. So if you shave somebody's eyebrow, just simply shaving, it takes something around 9 months to regrow, because most of the hair are in this telogen hair, they are not growing actively. But in the scalp, for example, nearly 80–85% of the hair are in the anagen phase, right? So most of the hair are growing. Again, for this reason, something around, for example, 10% of the hair is in the telogen phase or in the early anagen phase. For this reason, it is normal that you have some hair coming out when you, for example, take a shower or you brush your hair, you will see some hair coming, because these are the hair that they are at the exogen phase, and the new hair start to grow. So this hair growth is a cycling, it's continuously changing. We have diseases that in those diseases, only this hair growth cycle has changed, and they become, for example, much faster or much longer, so they cause different type of the hair loss. Sebaceous gland is oil-producing gland attached to this hair follicle, and sometimes we have the sebaceous gland on their own. For example, we call this Fordyce spot. You can see on the genital area or on the lip. These are standalone sebaceous gland. And then we have the sweat glands. The sweat glands, we have two types, the eccrine sweat glands and the apocrine. The eccrine is all over, except some specific areas, like part of the genital area or the lip, and they are mostly condensed on the palms and hands, palms and soles, and then they work as a thermoregulatory, and they are postganglionic sympathetic fiber denervation, and they are cholinergic. Remember, they are sympathetic, but they are cholinergic. And then you know that we have two types of sweating. One sweating is for the thermoregulation. If you can hot, you start to sweat, so this water evaporates, puts you down. And we have the emotional sweating. So you become ashamed, you become, for example, in a stressful event, start to sweat. People sweat from their palms, from their soles, sometimes from their armpits, right? You don't have it, you don't experience that one, right? That's okay. So we have the apocrine gland. What is the meaning of apocrine? What's the meaning of that? You know that we have three kinds of secretions. We have the merocrine, like exocrine, so the cells, the secretion comes like a vesicles. We have the apocrine, we call it decapitation secretion, so during the secretion some part of the cell is gone. And what is the last one? The holocrine, like the sebaceous gland, that the whole cells comes out during the secretion. So when you secrete, the whole cells shed off, right? So this apocrine gland, they are located only in some certain area, like your armpit, like your genital area, and they produce a proteinaceous material that the cause of the body odor is this one. Basically, this material by itself doesn't have any smell, but when it comes to the skin, it decomposes by the bacteria and then produce the body odor. So the type of the odor depends on the normal flora and the composition of this material in the sweat gland. And you see that the size of this apocrine gland is much larger than this eccrine gland. And we have a type of a specific combination of this type, this type called apoecrine. It's basically a large eccrine gland. And people who have hyperhidrosis, it means that extra sweating is the issue some people have, for example, in their armpit, in their palm, in their sole. They usually have lots of these apoecrine gland. So, nail unit, you have the nail plate, that is a translucent sheet of this keratinized cell. And then, on the contrary to the normal belief that the nails hardened by the calcium, basically it is called by the sulfate. These sulfate bonds that goes give the strength to the nail. And then you have these lateral nail folds, the proximal nail folds from the top, and this usually white half moon you will see here is called lanula. This is the part of the nail that you can see, matrix of the nail that you can see through the plate. You can see this lanula always on the thumb, but on the other fingers, maybe you see that one, maybe sometimes been seen, maybe not. And then from the sagittal view, you have the nail matrix sitting under this proximal nail fold, and then you have the nail plate. And then you have the eponychium, that is tiny layers on the base of the nail that protects the matrix. And you have the hyponychium, is the tissue that separates the nail from the digital skin. These are the different components that they got involved in different disease processes, so they produce different signs in the nail, and we are going to talk about this later on. So this was a very short overview of what is the structure of the skin. Now we are going to talk about how you are going to take a patient with the skin complaint. So like regular medicine, you are going to do this chief complaint history and also past medical history, medications, allergies. This is almost similar to the other disciplines. But when you see a skin eruption, a rash, you need to ask some more questions, deeper into that rash. What is rash about? For example, you should ask about when it starts, what are the symptoms? Is it pain? Is it itch? Is it burn? And which part of the body is involved, where it starts, how it spreads. These are all give you important clues in diagnosis. You are going to diagnose a rash based on what you get from these answers to these questions. And then one more thing that I want to mention at the beginning is that if somebody comes with a skin disease or a skin eruption and shows some part of the body, you have to, if you don't know what it is, you have to examine the whole body. So because you may find clues in other one part of the body that the patient is not going to show you, and we are not manipulated and give you clues to that one. Also, we do this total body skin examination. When we are talking about, we are looking, for example, such harmful diseases like skin cancer. So you have to examine the whole head to toe, everywhere, his skull, between the toes, between the fingers, genital area, everywhere should be examined to give you this, to provide you this information. So when we are going to talk about the skin diseases, the first thing you should do is you should describe them. As I told you, that dermatology is very descriptive and visual. So by morphology, I mean to talk about the form and structure of that skin lesion. this helps you in two ways. It helps you first to establish the diagnosis, and then it may enable you to communicate this, your findings with the other people, or you correlate what you see with what you read in the book, right? So you have to make a connection between what you see and what you read in the book. You will see a rash on somebody's hand, and you know that, for example, we have a disease called lichen planus that has flat top, polygonal, purple papules. So you should correlate that. What I see is this is the same thing that I read there or not. So this comes by correct morphology of the lesions. And for doing this morphology, you need first to carefully examine these skin lesions, and you have to use the correct descriptors. There are names for different conditions that we are going to talk about this right now. So first of all, we are talking about the primary lesions. The primary lesions basically says which class of disease it is belonged to. So these are different terms we use for the description of the primary lesions. Do you have any idea about these terms, if anybody knows these things? So first of all, we have flat lesions. The flat lesions means that if we divide it based on the size, for example, if they're less than 1 centimeter, we call them macule. If they are more than 1 centimeter, we call them patch. So the flat lesion means that if you run your finger on the lesion with closed eyes, you cannot find where is the lesion start, where it ends, right? You cannot find that. This is just a color change. For example, these are some examples of the macule and patch. You will see some hyperpigmented macules, hyperpigmented patch, depigmented macules, and then some hyperpigmented patch. You see the color is a little bit different, and also they can be less than 1 centimeter, we call them macule, and more than 1 centimeter, we call them a patch. On the contrary, we have papules and plaques. These are the elevated lesion. So if, again, less than 1 centimeter, we call them papule. If there is more than 1 centimeter, we call them plaque. When you are dealing with the papule and plaque, you know that the pathology is either in the epidermis or in the superficial part of the dermis. For example, these are different kind of the papules and plaque. These are small papules. You can see that they are coming in different distribution, and if there is a big, you will see some, it's called a plaque, right? Then we have nodules and tumors. These are a little bit deep-seated lesions. So when we are talking about the nodules and tumors, basically the basic pathology is sitting in the deep dermis and subcutaneous. So by examining, you can judge, for example, which part is involved, which part of the skin is involved. So again, they are divided based on the size, and these are some examples of how the tumors, how the nodules is working. If you touch them, you will feel there is some volume inside. They have some body inside, sitting inside the skin. Sometimes they are completely exophytic like this, they are on the surface. Sometimes they are sit deep inside the skin. So now we come to the lesions that contain fluid. So if again there's less than a centimeter, we call them vesicle, and the lesion larger than 1 centimeter, we call them bulla. So these are some examples of the vesicles and bulla, and usually these lesions happens when you have a separation either within the layers of the epidermis or between the dermis and epidermis. So if it is within the layer of the epidermis, the roof of this blister will be very thin, so usually they rupture so easy. But if the separation is between the dermis and epidermis, you have a thick roof, so they create a tense bulla like this, right? And then so many times, these vesicular bullous diseases, when they come to you, you cannot see the vesicle or bulla because they rupture easy. So what you see basically moist base with the rim of the scale at the surrounding, that shows that there has been a previous bulla here. See, you don't see any bulla here, but what you see is a moist base and the rim of tiny scales that is the remaining of the roof of the previous bulla. So, pustules, easy. Pus-filled vesicles, The pustules can be primary, the lesion can start with the pustule, or pustules can be secondary. Any vesicle or bulla sitting on the skin for more than 3 days, it tends to be a pustule because it is a pus field. So when you examine a pustule, you need to make sure that how fresh they are, right? Folliculitis is the inflammation around the hair follicle. Again, it can involve the top part of the follicle, so you will see a superficial folliculitis, or you can be involved the deeper part of the follicle, it will be like a nodule. The next one is the wheal. The wheal is an elevation because temporary edema on the upper part of the dermis. This is a characteristic lesion of the urticaria. Urticaria diagnosed by the wheal is elevation and a red halo around it that we call it flare. So a wheal and flare reaction is the hallmark of the urticaria lesion. Then we have the secondary lesion. The secondary lesions are the changes that happens by the external factor, or this happens as the lesion will go through evolution. So let's go through these one quickly. One of the first one, the most important one is scale. Scale is basically the accumulation of dead cells. Remember I told you that these stratum corneum cells, they come off cell by cell or small pieces that is not visible. If there is difficulty in keratinization, or for example, any difficulty in shedding, you will see big flakes of the scale that they comes together. And they come in different shapes. These shapes give you very important information about the nature of the disease. For example, sometimes they are thick silvery scale. Sometimes, for example, this is like a desquamation that comes skin off like a sheets. Or sometimes they are very fine scaling, right? Again, there are different type of the scaling. You will see, for example, here the scaling is on the leading edge of a plug, just on the edge, and sometimes the scale is following the leading edge. So we call it trailing scale. For example, these are characteristics of different kind of diseases. This is a fungal infection that they have the leading edge. This is erythema annulari centrifugum that has a trailing scale. This scale have a thick, scaly plug. That's a characteristic of psoriasis. Sometimes the scale is a little bit yellow greasy like this. It's called seborrheic dermatitis. So the quality of the scale gives you lots of information about the nature of the disease. Lichenification. This lichenification happens if you rub or scratch the skin so often. So you will see that the skin markings become more pronounced, more obvious. This is called lichenification. And then we have loss of tissue. If you lose only this part of the epidermis, we call this erosion. If the part of the epidermis along with the dermis gone, is called an ulcer. The difference here is that if you have an erosion, usually it heals without scarring. But if you have an ulcer, it heals with scarring. So it's important to recognize whether it's an erosion or it's an ulcer. So for example, these are a big ulcer. This is the pemphigus foliaceus, you have erosions, and this is a fissure, like a cut in thick skin. This is because of the dryness of the skin happens like that. So if any exudation or any serum exudation or pus accumulate on the surface of the skin, we call it crust. Crust is usually a sign of infection. If you see any crusted lesion, this is a sign of the infection. Or if you have a vesicular lesion or bullous lesion that the vesicles has ruptured, the secretions come to the surface and they dry there, it makes a crust. Excoriation, self-explanatory, erosion caused by this rubbing. And then we have the scars. So the scars can be hypertrophic, can be keloidal, can be atrophic. Acne scars is a very common problem, right? Because people have acne and they develop some scars. The difference here is that in hypertrophic scar, you have an exuberant tissue reaction after a trauma, but then it extends beyond the margin of the previous injury. We call it a keloid. This hypertrophic scarring is usually regressed by itself by time, but this continues to grow and it's painful. And then we have atrophy. if you lose some part of the dermis or subcutaneous fat or epidermis, you have different type of the atrophy. For example, here you have the atrophy of steroid injection into the joint, or this is an atrophy, for example, in some sort of this cutaneous T-cell lymphoma. This is the morphia, atrophy of the dermis. And close to the atrophy, we have a term called anatoderma. I told you I'm going to explain all these terms that later on, if you go open a book, you understand what we are talking about. This anatoderma, the hallmark here is loss of this elastic fiber. If for any reason the elastic fiber damage, then you will see some small depressions or a little bit elevations. That is called anatoderma. It can be primary. We have primary anatoderma. We have anatoderma secondary to some other inflammatory disorders. Burrow, a fantastic lesion that the mite of the parasite go into the epidermis and they lay eggs. For example, it's a scabies. It's a very itchy disease. You have the burrow and you have a little bit vesicle at the end of the burrow where the mite lives. And this is another burrow. It's a serpiginous line. Telangiectasia, dilated vessel seen through the skin. It looks easy, but it comes in different shapes, and each of these shapes, for example, denominate a specific disease. For example, this mate-like telangiectasia is a patagonomonic for scleroderma. You can see linear or arborizing, that for example, in some sort of skin diseases, you can have this arborizing telangiectasia, and the telangiectasia of this nail fold, again, is a pathognomonic sign for the systemic sclerosis. So now things get a little bit tricky, bleeding into the skin. So we have the extravasation, and then again, based on the size, you can say if it is less than 2 millimeters, it's called the petechiae, and if it is more than a centimeter, you call it like an ecchymosis. And some people, in some categories, they say purpura if you have a mixture of these two, or you can say purpura if they are standalone, between 2 to 10 millimeters. So what is the common cause of this purpura or ecchymosis? If somebody comes with the purpura ecchymosis, what you are going to do with, what investigation you are going to do?
How about bruise?
Yeah. What's investigation, what lab investigation you are going to ask for this bruising?
Biopsy.
Before jumping on the biopsy, for example, one of the common causes is thrombocytopenia, right? So you are going to do a CBC, says what is the platelet number, right? And then the purpura can be non-inflammatory, means that just the extravasation of the blood vessels outside, or can be inflammation of the blood vessel wall, so we call it vasculitis, and the hallmark of this vasculitis is a palpable purpura, a purpura like a papular purpura. And then you have, again, purpura can be reediform, it means angulated, sharp border like here. This happens when you have arterial occlusion. Like for example, DIC, disseminated intravascular coagulation. These are usually a life-threatening disease. Or you have purpura that they are not retiform. They have indistinct border. They are not angulated. So these are usually because simply of the extravasation of the blood vessels outside. This is, for example, a senile purpura as a result of the dermal atrophy because of the chronic sun exposure. Now, how you can recognize, for example, this is a purpura and this is not, for example, a erythema, a simple redness of the skin. How you can differentiate that? Okay. By pressing. So we call diascopy. You, for example, put a glass slide, or you, for example, you are pressing. If the color vanishes, so it is only result from the dilation of the blood vessel. It's called erythema. But these are non-blanchable. By the pressure, you cannot get rid of those. So cyst comes in different forms, different places. It has a wall inside, and the comedo is the prototypic lesion of the acne, which means that the opening of the hair follicle is clogged. So we have open comedones and we have closed comedones. So it depends on whether this opening is, the hair follicle is material open here or is closed. So these are the prototypic lesion of the acne. We have callus and core. These are the trauma-related lesions, usually on the feet. So let's go this a little bit faster. So again, one of those tricky things is called erythroderma. Any skin disease that affects more than 80% of the skin surface, we call it erythroderma. So erythroderma is not a diagnosis, it is just a presentation, right? So most of the time, the reason for the erythroderma is expansion of a pre-existing disease, like psoriasis, like for example, different kind of eczema, like cutaneous T-cell lymphoma, and in some cases, it is idiopathic. So you have targetoid lesion, target lesions. There are three colors. For example, in erythema multiforme, you have the central part, dark patches, dark part in the center. You have a whitish halo. This is because of the edema, and the red halo around that. So this is the prototypic lesion of the erythema multiforme. Sometimes they are targetoid. You have only two colors. And then poikiloderma, when you have a combination of the atrophy, telangiectasia, hyperpigmentation, hypopigmentation. This is again seen sometimes in skin cancers like cutaneous T-cell lymphoma or as chronic sun damage. We have sclerosis, means hardening of the skin due to excessive collagen deposition. And then you have scleroderma. It's a group of disease that their hallmark is this hardening of the skin. And side by side, we have scleroedema. This scleroedema, please don't mix it up because most of the time in the cases, you mix these two terms together. This is scleroedema. Again, it is hardening of the skin, but because mucin deposition. This is seen, for example, in diabetes or paraproteinemia. So this is scleroedema is different from scleroderma. These are two different entities. The names are very similar, but they are different. So how you are going to describe a lesion? Let me see how much time. Okay. So if somebody robs you in the street and then you go to the police station and they say, okay, who was robbing you? And you will say, it was a human, right? This is exactly when you rob in your referral form, the patient comes with a rash. It doesn't give you any clue, right? What is it? Just say it's human. Then you start to describe. It was male or female, dark or white, tall or short, hairy or bald, whatever. The more you describe, so you get more into the details and gives you clue what is the culprit, who is responsible for that. The same thing goes here. So when you want to describe a lesion, first of all, you should describe what is the primary lesion, what is the secondary lesion, and then we're going to talk about the color of the lesion, the demarcation of the lesion, and then the shape of the lesion. If the lesion is single, that's it. If there are multiple lesions, how they arrange according to each other. And at the end, where is the distribution, which part of the body is involved. So let's talk a little bit about these things. For example, skin lesions can have different colors. Basically, these are all red, right? You can say these are all red, but they are all different shade of reds, and in my eyes, they are totally different. So this red is totally different from this one, this is totally different from this one, this is totally different. This is a beefy red, for example. This is a salmon red, this is a dark red. So there are different shades of the reds. So this is the key. I told you this is descriptive. You have to train your eyes because red is not all the red is the same, right? So again, here you can see the most important thing I want to mention here is the erythema. This comes in the notes very often that erythema is not a color. Erythema, by saying erythema, you say that the lesion is blanchable. right? It's not non-blanchable. So you make a distinction whether it is extravasation of the blood vessel or it's a dilatation of the blood vessels. So when you say erythema, but again, for example, you can have yellow lesions, you have dark lesions, blue colors, so all the colors you can see. So you have to describe as accurate as possible what is the color of the lesion. A great, I can say, learning barrier is when you're dealing with the skin of color. So all the colors you see in white skin people are totally different in darker skin types. For example, all the reds become a little bit bluish, right? Or for example, sudden redness you cannot see even, right? So, for example, these two lesions are the same disease. So this is lichen planus. You see that how they are different in different skin color. Or for example, this is psoriasis, for example. You will see here a salmon colored patches, but when it goes to the darker skin, this is basically like a hypopigmented, it's like a white skin. So when you are examining the people of the skin of color, you should remember these nuances in the skin tone that affect what you see, right? It looks like that you look at the lesions with the dark glasses, right? So some lesions are very well demarcated, means that you can find a point and say, okay, this point, then it is the border between the disease and non-disease. But some disease like this, there is no, there are no clear distinction between the disease area and non-disease area. So this is, for example, on the other side, this is, for example, this is a cellulitis that you will have, you don't have any very distinct border, but on the other side, you will have a very sharp border. Or, for example, you will see that some lesions are very clear-cut. This is the place of this external factor. Or sometimes they are confluent, they are coalescing. So demarcation is well demarcated or not well demarcated means a big difference. This is erysipelas, well demarcated. These are both the same family of disease. This is the cellulitis. This is not well demarcated, right? Then you have to palpate the skin. It is soft, compressed, tender. The quality of the touch is important. And the shape of the lesions, there comes in many different shapes. So if you read in the textbook again, you will see they're talking about the flat tops, dome-shaped, filiform, pedunculated, verrucous, umbilicated, like a whole dent in the center. There are different descriptives you use to tell what it looks like a good lesion. And the configuration, so how the lesions arrange together. For example, you may have an annular lesion. The annular lesions means that there are some central clearing. It shouldn't be completely round. So if you have any central clearing, it's an annular lesion. Or it's a plaque-like lesion, right? It's again an annular lesion. It's a grouped lesion, right? So if there are more than one, you want to tell how they arrange together. Again, for example, this is a linear serpiginous. This lesion here is like a Christmas tree pattern, so you will see mostly on the center and they follow the skin tension lines. This is an annular lesion again. This is semicircular or archiform. These are the way that you describe what the lesion is. And then you may have funny things that comes as a linear skin lesion. Sometimes you see the lesions like a line. So many things that cause this linear lesion. The commonest one is this, when the lesion happens with the, as a result of the external factor. For example, if you're allergic to something and it rubs through the skin, you will see a line of the lesion right at the place of this contact. Sometimes the linear lesions are dermatomal. Some diseases affect one dermatome, like the herpes zoster. So you see the lesion in a dermatomal pattern. Sometimes if you have infection, for example, like a plain wart, if you scratch, you will see the line at the site of the scratch. It is the linear, for example, line as a result of the scratching. And sometimes the lesions goes in this Blaschko line. These are the lines that the cell migrate through the embryogenic phase. You won't see normally, but if one clone of the cells become involved, so your lesion is a blush line. These are like a S-shaped line on the trunk. And one funny thing is this sporotrichoid lesion. This sporotrich is a fungal infection we are going to talk about later, but it tends to develop nodules along the lymphatic. So it's called a sporotrichoid pattern. It means that you have the lesions spreading along the lymphatics. And the distribution. It seems that the skin is a uniform structure, right? So if you have a disease, it should affect everywhere normally, but it is not. So many diseases, they have to affect a specific part of the body. For example, you have the psoriasis that affect the extensors only. You have the atopic dermatitis that in different ages affect different part of the body. Sometimes they are, for example, symmetric. Sometimes they are asymmetric. Sometimes, for example, generalized. Or, for example, they coalescing. It means that they start separate and they try to merge together. So all these shapes, again, in the description, will help to narrow down your diagnosis. When you see a rash, you don't be frightened. So by proper description, then you can come and create. Let's talk about this later. So we have some clinical signs. Again, you will see that commonly, one is the Mikulski sign. Again, it is in a blistering disease. It is the lateral pressure dislodge the layer of the skin. It means that there is a separation either in the top part of the epidermis, in between the upper part of the epidermis. You have the Auspitz signs, that is a characteristic of a psoriatic lesion, that if you scratch the scale, you will see some pinpoint bleeding. And then you have this dermographism, that's a type of this physical urticaria. If you scratch the skin, you will see wheal and flare reaction at the place of the scratching. And another one is the barrier sign. This is the mastocytosis. This is a rare disease. Let's skip that one. And then, when you do all this examination and you describe the lesion properly, then you can categorize the lesion based on what you have found. For example, we categorize in papulosquamous disease. These are the diseases that the primary lesion is papular and scaly. We have eczematous reaction, that this eczematous reaction are a little bit papular or plaque lesion with a little bit moist scaly. We have vesiculobullous disease, right? So if you recognize the primary, the secondary lesion and use a good descriptor, so you can categorize, okay, what is this I'm looking at? And based on that, you need to create a differential diagnosis. This differential diagnosis is very important in many medical fields, especially in dermatology, because people got trapped that they look at lesion and they see the first thing they say, that's it. They cannot produce a differential and they cannot do, for example, proper investigation, because in most cases, for example, through accurate examination, they want you to have some sort of differential. So you see, okay, this is what could be, other things could be that I can rule out. For creating a differential diagnosis, there are many ways, but this is one of the simple things, that if you, for example, see a papulosquamous lesion, the first impression, what is the mini-tears, what can be the worst case scenario, and the esoteric disease, then rare congenital disease or metabolic disease, something rare. So this is the way that you create a differential diagnosis. And these are the reaction patterns I talked to you. For example, you have the papulosquamous disease. If you look at this, you will see, for example, this is a papulosquamous disease. If you look at this one, you can say at least this is a vesiculobullous condition. These are, for example, an eczematous condition. So according to this primary and secondary and descriptors, you can come to know what is the reaction pattern, and according to that, then you create your differential, and then you take from there. We have some bedside diagnostics. We are going to finish shortly. So one is the dioscopy, that you put the glasses slide. It helps you to distinguish between the erythema and purpura. And and sometimes you can see even deep-seated granuloma, like for example in cutaneous tuberculosis or tuberculous sarcoidosis. If you do this glasses slide, you will see a actual jelly nodule. This shows that the deep-seated granuloma. We have the dermoscopy. This is a tool that we use to see the top layer of the skin with the naked eye. So we'll talk about this later. And then we have the Woods lamp examination. This is a low output UV. In a dark room, you shine this UV light. And this is good, for example, sometimes in some fungal infection that they have a red fluorescence, for example, in some sort of the tinea infection, or for diagnosing of the hypopigmentation or depigmentation. In normal light, you don't see that much, but when you put the Woods lamp, you will see clearly the demarcation of the white patches. Same thing on the hyperpigmented lesion. If they are sitting on the surface of the skin, usually they will be highlighted under the Woods lamp. If they are inside, you won't see that magnification. So, and then we have the KOH preparation. This is again a bedside test. For a scaly lesion, you take a piece of scale, you put the KOH, it's digested the keratin, and you see the fungal element. In diagnosis of superficial fungal infection, you can see the hyphae. Again, we are going to talk about this later on. And then zinc smear, it is useful in, again, vesicular-bullous lesions. You just scrape the base of the lesion, and you look under the microscope. There are some diagnostic features for a few of them, especially if you're suspicious of the herpes simplex. These are simple tests you can set on the bedside of the patient and give you a quick clue. And the last one I think is the scraping. Is for the scabies. If you are suspicious of the scabies, you can find the burrow and then you scrape it, and then you will see sometimes the live mite under the microscope shining and laughing at you, right? We have some clinical tests. We have the patch test and prick test. Again, this is most of the time confusing. What is a patch test? What is a prick test? What is a patch test? What is a patch test?
You put a patch, and then you
Which
see
kind of reaction you are looking for?
hypersensitivity.
Written there.
What?
Yeah, written there. Just look at that. Read it loud. Help me.
Hypersensitivity. What? 4.
4. So this is the difference. In patch testing, you are looking for a delayed type hypersensitivity reaction, right? When you have a contact dermatitis allergic reaction. In patch testing, you put something on the skin and you read it after 72 hours. So this is for the delayed type. In prick test, you are looking for immediate type hypersensitivity reaction. Somebody, for example, type 1. So you put the material on the skin, you make a prick, and you read it in 20 minutes, right? This is the thing that people most of the time confuse these two tests together. And we have another test, it's called Papules, that just you prick the skin with a needle, and it shows, positive test shows an exaggerated inflammatory response. This is, for example, in some diseases like Behçet disease or pyoderma gangrenosum, this is again helpful in diagnosis. This is called Papules. And then the last but not the least, we do a skin biopsy. That is the easy thing to do, right? We have different type of the biopsy. You can do, for example, an excisional biopsy, a shave biopsy, a punch biopsy, a cell sterilization. And the type of the biopsy depends on which kind of the lesion you are looking for. For example, if you are looking for melanoma, you are not going to use a shave biopsy because the depth of the lesion is so important. But for example, for inflammatory diseases, you can use a shave biopsy, you can use a punch biopsy. These are some histopathology patterns. These that usually in clinical setting, even you can people use that terms. For example, you have different kind of patterns. Again, dermatopathology is a low magnification diagnosis. In dermatopathology, we are not looking at the 100, we are looking at the cells. We are looking at the pattern. So if with the 40 magnification, you can recognize 95% of the diseases. And you see how they different shape they are. When you do a skin biopsy, for example, you cut a tissue around 4 millimeter, right? And then you send to the pathology, they cut it in slices around 4 4 or 10 micron, and they look at the under the microscopy, right? Usually, on average, if they have good cut, they look at 2% of the tissue you send to them. So, for this reason, sometimes you have to ask the pathologist to make more cut, look more into that sample, because they are not going to look at everywhere, right? They just make a cut and they look at their cuts, right? And it is always good to have a good correlation between the pathology and the clinical finding. So, most of the skin disease based on the immunology. So we are going to test your knowledge on immunology, right? Ready? So, what are the skin immune system? What is the basically immune system? How many components do you have in immune system? In a nutshell. Come on, guys. Immune system. We have innate and adaptive. Yeah, that's it. We have innate and we have adaptive. So what is the innate immune system?
That is the first response.
Okay. Read there. Read. Okay. Non-specific, quick, no memory, right? Okay. So what are the components?
Yeah, natural killer cells are there. The complement pathway too is there, and we have the mast cells, macrophages, and
Right? These are the components of the innate immune system. Okay. First line defense. And how they work, this immune system, innate? Pattern recognition. What pattern we have?
Antigen.
What's the name of the pattern?
Taps.
PAMS and DAPS, right? Pathogen associated and damage associated. These are the two things. So if somebody says immunology, at least these are the things that should come to your mind. Innate immune system, work on this pattern. How about the adaptive? Specific,
Yes.
delayed, memory. What are the components of this adaptive immune system?
The T2.
B and T cells.
B and T cells, fabulous. B and T cells. So you have the antigen specific, cellular, humoral, and they are working based on the antigen presentation and clonal selection, right? Okay. So this is the skin immune system. The dendritic cells, the mast cells, the macrophages, and the keratinocytes. These are all part of the innate immune system, and we have many other T lymphocytes that's running around and part of the adaptive immune system. So, I hope you know all of this, right? You know them. So you're going to test that one. Okay. What are the hypersensitivity reactions? How many types?
1 through 4.
Okay, type 1.
Immediate.
Okay. Type 2.
Antibody mediated.
How it works.
Complement.
Because this is the type that nobody knows. What is the type 2?
Complement system.
How it works.
The antibody can either go onto a receptor, block a receptor, or go onto cells and activate complement.
And where is the antigen?
The antigen can be a receptor or it can be just on the cell as a marker.
Okay. Type 3.
Serum sickness. Or,
Yeah, complement.
yeah.
It's a complex of the antibody and
Okay,
the marker.
great. You did great. Because the only thing is here that in type 2, the antigen is on the surface of the cell. In type 3, it is floating. Right? So this is the main distinction. And then the delayed type hypersensitivity reaction. And then we have the T cell activation. So how T cell activated? This is tested very often. How T cell activated?
Antigen presented to the
To
MHC.
what? To what?
To
Antigen
the-
presented to what? How the
MHC
antigen
signals.
presented? MHC class.
1
One
or
or
2 to the TCR, and then there's a co-stimulatory.
This is a
signal.
T cell activation, right? This is antigen presenting cells comes with the MHC class 2, right? This is MHC class 2 is only on the
Oh, yeah.
dendritic cells, right? So it produces the T cell receptor and it needs a co-stimulatory. What is the co-stimulatory?
B7, CD28.
Fabulous. And the last one is the cytokine signaling. So the fate of this T cell depends on which cytokine you have. So it's whether it's going to be, for example, a Th1 or Th2 or Th17, right? Okay. So what is this Th17 cells? Again, this is the thing that hardly anybody knows. So what is the Th1? Let's just start from the Th1.
Cell mediated.
Okay, what the Th1 does?
It calls recruitment of macrophages and activates more T cells.
Uh-huh. And what is the main cytokine? Isn't there? Okay. How about the Th2?
Humoral immunity, so activating B cells and then activating antibodies.
Main cytokine?
4, 5, and 13.
Okay. Th17?
Causal helpers.
I know there's Allison.
What is the natural role of the Th17 in the body?
Chronic neutrophil recruitment.
So basically you have intracellular organisms like viruses or intracellular organism, you have the Th1. You have the big organism like a parasite, you have the Th2, right? And for the normal bacteria and fungi, you have the Th17, right? This drives the inflammation. So these are very important nowadays. We have targeted therapies for many of the skin disease. So we use, for example, antibody against these cytokines, and they are very effective treatments. So we are going to talk a lot in different diseases about the cytokines because knowledge of this is the future of the medicine, right? Okay. I think we talk about these things, CD4 cells and the Th17 and CD8, and that's it for today. So first of all, any question?
Would we get access to your presentation?
Of course, yes.
Thank you.
Then what else? So what will be the plan for tomorrow?
Same time lecture?
No, the material, for example. So what these people are going to do today?
An intro today, and I'm pretty sure tomorrow is bacterial infection.
Okay.
Yes.
So because if you go through that, we can move a little bit faster. And I can tell you, because when it goes to the clinical part, then there are some tips and tricks that you read, for example, a disease, and then you will set 10 information, but from this 10, only 2 is very important. But you cannot recognize which 2 is the key one, how you differentiate, right? We are going to focus on that 2. But I want to make sure that you know the remaining 8, right? So please go through this, and then tomorrow we are going to work about the bacterial infection, and I have a bonus for you at the end. If you be fast, we talk about a little bit some extra things alongside that. Okay? So I usually take a little bit feedback from the people, so how I came across, and then if sorry for my English, sometimes I do not speak very well, I know. So bear with me, right? Okay. You are going to sit here and be looking at me, stare at me, or you're done, right? Okay.
No,
Thank you so much.
present
So,
first.
first of all, I will be here by, I think, by time we are here at 4 o'clock, yeah? So I will be here by 4, so I'm free, I don't have anything to do. I'm open to any questions regarding the material, regarding outside thing about the derm. And then feel free to come if you have extra time. Again, we can go through some of these subjects more and more. We can have some more practice. If you have time, we can show some cases to you, for example, to practice on these skills. And then I'm open to any questions. Of course, I don't know everything, like every human being. I'm not aware of everything, but I try my best to be as helpful as possible. Okay? Thank you so much.
Will you be inside this room or head or something?
He's the boss.
Thank you.
You're welcome.